Did we want to start right at the top of the hour, or did we want to wait for a couple minutes?
Do what we did last time. Start like at 03 or 04. We'll be on for an hour and a half. I mean, it went long. What do you think, Marcus? Are you there?
Yeah, I'm here. I'm fine with that. Yeah, I think last time was smooth, so yeah, we can do the same thing.
Talk about pop-ups. Forgot about that one. Perfect.
And just to let you gentlemen know, I do have another event right after this one, so I'm just double checking the time on it.
I'll make sure we end maybe 5 minutes before, or however much time you need.
Okay, because it's right at 12:30 Pacific time. So if we could be done by 12:25, that would be perfect.
So can we try to get can we try to get done closer to the hour mark, and then save a little bit more time for questions versus?
Yeah, I'll go through.
Okay.
I'm showing 2 minutes after. Are we ready?
I'll give 1 more minute and then we'll go.
Perfect. Are we ready, gentlemen?
I'm good.
Yes, we are.
Hello, and welcome to Clinical SBIRT Success, where coding and patient success can coexist. My name is Connie, and I'll be in the background answering any WebEx technical questions. If you experience technical difficulties joining the WebEx session, please dial 1-866-229-3239. Please note that as an attendee, you are a part of a larger audience. However, due to privacy rights, we have chosen not to display the number or list of attendees to everyone on the call today. All attendees will be in a listen-only mode throughout the duration of today's call. As a reminder, today's call is being recorded. We will be holding a Q&A session at the conclusion of today's presentation. You may ask an online question anytime throughout the presentation today by simply clicking on the chat icon located on the floating toolbar at the top of your screen or on the right side of your screen. With that, we invite you to sit back, relax, and enjoy today's presentation. I would now like to introduce your presenter for today, Joseph Hurley, Revenue Cycle Director for Oregon Health and Science University. Joseph, you now have the floor.
Great. Well, thank you, everyone. I feel honored for being here, and I'm really actually excited to talk to you about SBIRT and really describe how some of our early adopters have really been able to be SBIRT billing innovators. It's an honor, again, like I said, to be here, and I hope that as I talk about billing, this is not harmful and puts anyone to sleep. So my name is Joseph Hurley. To give a little history of what a revenue cycle director is, my role in Oregon Health and Science University is I'm employed by the Family Medicine Department. I'll talk really in specific about who we are. Right now, I'd just like to give you a little heads up about what I do. So, yes, I do finance. At the same time, I do provider training, I do clinic training, and an example of that is if we hire a new provider and he would like to start doing group visits, so we'll work together on creating a template, and then we'll work with our EHR on how to do that, how to do documentation. So I get the touch of finance and clinical, which is really rare in a healthcare setting. So it keeps me young. Really what I get to do is focus working with physicians, train them in Epic, train them on how to do certain things with our Epic as our electronic health record. I get to train the front office, I get to train the back office, and it's a really, I'm in the trenches with everyone, and it's actually a very fun job. Every day is something different, and it's extremely satisfying. So as we talk about our webinar, just know that I deal with probably what all of you deal with every day. So just as a warning, I said this in the last webinar. About a month ago, I talk in my sleep, and my wife in the morning said, "What is ICD-10?" So yes, I do use acronyms, and I even do it in my sleep. It's a sign of a nerd, or it's a sign of someone who works too hard. But I'm trying to curb that because sometimes I'll say acronyms during the webinar. Just as a warning, I apologize for that. It's in my blood. It's what I do every day. So I really hope to not do that. I hope to be able to explain everything in detail so you understand. And just so you know, I've been to many webinars where I wonder why I even was present because I didn't learn anything. So just so you know, we are going to get into the meat of what is SBIRT. We are going to actually be very specific to billing, and my goal is through the question and answer even get more specific. We are going to talk about the meat of billing for SBIRT. So if you're on this call and you're a clinic, you're an outpatient standalone clinic, you're a primary care center, you're a health system that has primary care attached to your hospital, we're going to talk about all these different specifics and be very detail-oriented. So you came to the right place. You know you came to the right place if this webinar is related to SBIRT. And just so you know, it stands for Screening, Brief Intervention, and Referral for Treatment. I want to really pay note to this website ahead. It's our OHSU Family Medicine Oregon SBIRT webpage. And a lot of what we're going to show videos on today are going to be here. Some of the videos might, because of the bandwidth and capability of your computer, might not come out so clear. So as just trying to be friendly, literally if you go into Google and you type in Oregon SBIRT, this is the first page that appears. And a lot of what we're going to talk about related to reimbursement and to some of the videos we're watching are found right here. So just so you're aware of what we are in family medicine, we really, our main approach of our SBIRT initiative was in the outpatient primary care setting. And then we actually did expand it to include hospital services and emergency room departments. A lot of what we're going to talk today is based in the clinic setting. So if you're a clinic that is attached to a hospital, we'll even get into how you bill, because it is different, as well as we are going to focus on the primary care setting and be very, very specific in the billing. And again, I'm open for questions, and I think we can all learn together. So some of the outcomes of what I want to talk today, just so you know, I'm going to really explain of how our SBIRT program operates and how it was embedded within our clinical outpatient setting, our community health center clinics, because we have a few of those, and briefly touch on some of those outpatient clinics that are associated with hospitals. So literally standalone primary care and health centers, or primary care, FQHC, RHC, those federally qualified healthcare centers or rural healthcare centers. I'm going to even focus on all those clinics that are attached to hospitals. My main goal is to talk to you about how the business side and the billing side really were integrated into SBIRT. I'm going to talk about how we made our electronic health record work for us and make our billing more efficient. I'm going to talk about how our documentation and billing was really made easy for our clinicians. And then I'm going to talk to you about how our billing practices and workflows can really be crossed over and implemented in your practice. And to get even more specific, I'm going to focus on something new, which is a partnership with the business office leadership. A lot of places, and you'll notice recently I've seen this a lot, is the clinician champion, while at the same time we're focusing on a business office champion. We're going to focus on front-end training. We're really going to talk to you about how we, as a primary care practice, showed incentives of why SBIRT can be done and should be done in the primary care setting. And we're going to focus on team-based coordination. Just so you know, I come from a primary care integrated into mental health. So the focus is still, a medical primary care, but we've also integrated mental health into our model. And as I talk a lot about the primary care aspect, we all know there's a clinician champion. I do want to point out that there are business office leaders, and you'll kind of wonder, why are he showing me these slides? I attended a national conference just a few months ago where a business CEO got up and said, you know what, I understand the clinician champion, I understand why we need to have it, but don't forget us. And he even himself stood up and said, I feel like we're kind of like the Batman, while the physician champion is the Superman. And our medical director is highly into Spider-Man, so he also wanted to not leave a note about these heroes. And so he put how the business office champion can be Batman, your physician champion can be the Superman, but don't forget about all the other people who are working. It's not just the physician or the business leader. As we're moving toward primary care model homes and medical homes, our staff is working to their highest degree, and so don't forget about them. We've really focused on team-based coordination and care within our primary care as well as our hospital staff. So don't forget about these people who work just as hard as clinicians and business leaders. To give you a little history about who we are, OHSU stands for Oregon Health and Science University. We are one of the top-ranked teaching hospitals in the nation, in the top 10, and I like to brag about how our department is one of the best academic family practice departments, and we're really excited because programs like SBIRT and all these different initiatives we've done have really helped us stand up in the nation. We've come from a tiny 2-doctor clinic to this nationally ranked major department, and a lot of it is really our way of and our work ethic and how we really approach situations. We are also a really integrated primary care location within a hospital. So we are those primary care clinics that are independent, but at the same time, we're connected to a health system. And as I keep pointing out in these slides, it's really complicated what we do. But if we can do it in a severely complicated structure, then that really means you can do it. So again, we have 4 clinics. We see about 169,000 patients a year. We have 3 hospital services where, let's say, a patient gets admitted, well, then our family practice docs are there at the clinics, and they then go to the hospital. When I say we're connected, we are truly a primary care connected health system. If a patient goes to our Oregon Health and Science University ER, then our primary care docs get notification, and they get to read the chart and they get to know exactly what happened. If a patient's admitted to the hospital, our primary care physicians get notification, so they can actually go to the hospital and meet the patient. And going a step further, when the patients are discharged, we have a system here where within 48 hours, there's either a home visit if the patient can come to the clinic, or within 7 days, there's a follow-up visit with our primary care provider. Because our goal in primary care, the mantra we say is every single admission to the hospital is a failure of primary care. And at the same time, we're integrated with the hospital that we work with so that if a patient is admitted, they actually get admitted to the family medicine inpatient wing where we have our family medicine docs who rotate. So we really try and integrate primary care, and we're really the integration of the primary care medical home into a hospital. We're proud of that. We have about 250 volunteered faculty located throughout Oregon. We have 50 teaching residents through first year to 4 years. We have a required third-year medical school clerkship. Now that got changed to 4 years. And we have a faculty of about 95 clinicians and educators and researchers. So we're pretty big. We're also pretty complicated. So we have 5 Oregon State Tier 3 primary care medical homes. You may wonder, well, how do you have 5? We just we just integrated a new primary care practice into our location just recently. So now we have 5 clinics instead of 4. We have integrated our primary care medical home teams into inpatient teams like I just talked about. That's been hugely successful, one at making sure when a patient gets admitted, they see their primary care doc. And let's say they get admitted and the primary care doc isn't there, most likely that person will visit the patient in the hospital. Nothing soothes a patient better than having their primary care doc with them during an emergency. So we're also, as you're kind of hearing, we're extremely complex. We have different ways of billing, different ways of doing services. So if we're successful at SBIRT, then that means you guys can be successful as well. And hopefully you're in the way you do your billing and the way you perform your services, you're not as complicated as we are. As we start talking about SBIRT, this seems to be the major approach. Well, we don't know. How is SBIRT done? We really don't know if it's covered. Let me just wave this magic wand and let's see what we can do. This is kind of the usual approach we get. We also get this approach where a biller comes to a physician and says, you need to do these codes. Now, as you look in front of you, you see various ways of billing. You find commercial insurance, you find Medicare, you find Medicaid. But wait, Medicare just introduced these 2 new codes. So now we've got various codes and various ways of doing billing that are confusing for physicians. And, physicians, they don't really care about the billing. Their major focus and care is on patient care. So it's very interesting when a person like me comes to a healthcare provider and says, you need to start billing for these. So as we talk, this was a major focus. You notice these 2 new codes in front of you. Look at the top, no co-insurance and deductible. So now we have a way of screening and doing treatment for alcohol and drug abuse that has no patient cost. These are specific to Medicare. So this is going to play into our discussion in just a few minutes. Here was our approach to SBIRT, heard loud and clear. Let our providers do what they do best and treat patients. So how can we create a system for billing for SBIRT that doesn't complicate physicians? For many of you out there who do coding, you know that when you try and teach a physician coding, usually you get glazed eyes. I hope that during this presentation you have enough coffee or energy drinks to keep you awake, because that's usually the outcome of when you try and teach anything related to coding and billing, unless you're a coder or biller. So the part 2 of this is we wanted to create a system also that really maximizes our electronic health record or health information technology. We can't stress enough how much we talk to providers, we talk to our front office, and we tell them, you need to work to your highest degree. Well, that same thought applies to your electronic health record. Why not make it work to the highest degree it can? So here was our approach. I like the if you build it, they will come. Instead of fighting with physicians on how to do billing and trying to approach it in a way that usually isn't successful, we realized that if we were to integrate billing into actually training providers on how to document, that would be an easier approach. Because instead of training physicians on how to code, we're doing what they understand best. We're training physicians on how to document. So we thought of two ways we can really optimize our electronic health record, and that is Epic. Now, I won't say Epic is the most brilliant, amazing electronic health record out there like its advertising does, but Epic can be extremely useful. Epic has what are called smart phrases. That's related to documentation. And it also has something called a smart set, which I'll show you in a minute. Integrating these two pieces of technology has extremely streamlined how we do our billing. In fact, it has actually made it easier for physicians. And I'll even note, even those physicians who can barely type and get extremely horrified using a computer system to do their typing, it's been able to help them out. So here's that one reason, again, why we really focused on how to make everything behind the scenes in coding is because our healthcare providers aren't paid to code. They're really there to treat patients. But the minute they code wrong, you get this reaction. I'll really focus that, in my experience, the patient can have the best possible care from a provider. The clinic staff can be the nicest people in the world. When a patient checks in, the front office could check them in with a smile, and those patients can feel at that moment that they've had the best possible care ever. Your patient satisfaction scores couldn't be better. The moment they have a billing issue, that great visit suddenly turned into the worst day of their life. All of a sudden, everything good the clinic did has been turned negative because of a billing issue. So the best way to lose your patient satisfaction scores and have them lowered, or to lose patients, is to have billing errors. Because patients will go to where they can get maybe mediocre care just because they can guarantee there's no billing issues. That's a scary thought, but very true. So at the same time, we did a lot of payer involvement. Made me kind of feel like, oh, wait a second, there you go. When we started this, we worked with our Medicare intermediaries. We worked with our Medicaid state, so we worked directly with Medicaid, and we worked with our top payers. As you had the slide before, it kind of felt interesting. I feel like I'm doing something new. I felt a little bit like Indiana Jones, but then actually starting to work with each of these locations, it quickly turned into the picture you see there. We have 3 Medicare intermediaries we work with. As you know, each of them are extremely difficult. You'll get one answer from one person, and yet you get a denial stating the exact opposite of what you were told by that person. So we have Cahaba, NGS, and Noridian, who are our Medicare intermediaries. I'll tell you that the only time in my life that I've had good experience with Medicaid is here in Oregon. They are amazing professionals. So working with our state Medicaid, they actually saw the big picture of Medicaid. They were a breeze to work with. I cannot say that about anyone else. I'll also say that we had to work with each of our payers, call them, and ask them, what codes do you cover? What is your documentation requirements? And we then submitted it to them, and we actually worked for 6 to 8 months with each of our payers to make sure that our medical documentation passed the mustard. And I'm happy to say that after a lot of this work, even though it did feel like we were kind of ambushed and at the same time on fire in the picture you see, we were able to create something that we're going to present today. So I'm showing you, this is a copy of our Epic Smart Set. If you don't have Epic, the word Smart Set for Centricity and for Meditech and for all the different next gen, there's different terminology, but there's still the same ability to do this. As you can see in front of you, there's a place for you to have a progress note. Here are your ICD-9 codes, your International Classification for Disease codes. Again, if I'm speaking billing lingo, please stay awake, have a coffee, make sure you're awake. There are medication orders, there are lab orders, there are patient instructions, there are referrals, and I'm going to dig into this in a second. And there's our 2 SBIRT codes. Now you might notice he just showed me 8. Why are there only 2 codes here? I'll get into that. So I'm going to expand it. So here is our SBIRT progress note. I'm going to actually show you in a little bit a video that walks you through 2 examples of how to document. And we're going to dig into what documentation requirements we were told that has so far passed 100% audit. These are the ICD-9 codes that can be linked with the visit. These are all the medication orders, and we click on that, and this drops the order that the physician can sign, and then it goes to our staff to administer or to have it given to the patient before they leave. It has lab orders that again drop to be signed. Here are our patient instructions. Here are our consults. We actually have healthcare professionals who are either licensed clinical social workers, unlicensed social workers, or they're psychologists who work at our clinics. And I'm going to talk about their billing as well. And then talking about your level of service, let's get into this. Basically, this Epic Smart Phrase is a billing tool. This opens up in the patient's chart. The provider can click on this button, do their documentation. Depending on the diagnosis, they can click on this, click on any medication order, any lab order, any patient instruction, can do a referral, and then this is their level of service. So when they close the encounter, by taking a minute to click through these, they've just completely documented their encounter. So they can even do this in the patient room while they're rooming a patient and talking to them, and literally leave and be done with their documentation. So this is an Epic Smart Set. Remember I told you Epic Smart Set and Epic Smart Phrase? Well, we're going to head into the Smart Phrase in a second, which is basically a progress note. And it's got smart logic, so it pulls in patient information when you enter your Smart Phrase. I talked to you about level of service. This little tab here. We actually, talking about making our electronic health record work to its highest degree, we put if-then logic into our Smart Set. So depending on the payer, if the payer is Medicare, if the provider clicks on the time, let me back up. Oop, wrong way. So on the level of service, it has time. So if the provider sends 15 minutes, they would click on this little button. Now the if-then logic looks at the patient's payer and says if the patient is Medicare, if the patient is a Medicare HMOC, if the patient is a Medicare replacement plan, then the code changes from the 99408 to that G code that I showed you earlier. So still, instead of focusing on training a physician to memorize all these different CPT codes or have a coder do it for them, we just solved that issue right then and there. So again, I'm going to really talk about how our training was more focused on documentation than it was coding. Our goal was to have coding be behind the scenes. So what we really trained a provider was, this is what you have to do for documentation. So to fully document, you have to have a time statement. Well, the time statement's done in the progress note, but at the same time, for the coding aspect, we made it as easy as 15 minutes or 30, and then had the computer work behind the scenes to do the coding to make sure, depending on the payer, the code dropped that was correct. So instead of, again, training a physician to know 8 different codes, the system does it for them. You might ask, well, how can that work, or is it successful? And I'm happy to say that we've had 0 billing errors, and at the same time, we've had 0 physician complaints. In fact, they love the fact that now they don't have to memorize all these complicated CPT codes. And just to focus, the medical record will also, under the medication order and under the lab order, it will drop the CPT code that's required depending on the payer as well. So basically, this is a one-stop shop for coding and documenting. Now here's this, I know it says Epic Smart Set above. But it is part of the EPIC Smart Set, but this is this part. This is the EPIC Smart Note. So this actually will pull the patient information in. So had this person's name been Epic, and had this person been a male, it would say Mr. Epic. If it had been a female, then it would change it to the, it wouldn't be Mr. So the example here is Mr. Epic was given a, hopefully, I hope you understand this terminology. I'm going to even get into it in a little bit. But an audit or DAST are the paperwork required, and I'm going to show you examples of these for doing alcohol or drug addiction counseling and doing the screening forms. So if you had given a patient an audit or DAST, or you gave them both, this would actually say Mr. Epic was giving an audit. If it was a DAST, it would say DAST, or if it was both, it would say audit and DAST. Mr. Epic's score placed him into low risk, risky, harmful, and dependent. These four little attributes here, those are all part of the form, which I'll show you in a second. Let's say the patient decided not to continue with the discussion or was unwilling to continue, or you ran out of time. You still want to document that, and that's what this little option does. If it didn't apply, the person would just copy over it and hit backspace or delete and get rid of it. If the patient did go through with the SBIRT, here's the beginning of your documentation. So in discussing this issue, my medical advice was that Mr. Epic abstain, cut back to no more than 4 drinks and no more than 14 drinks per week, cut back to no more than 3 drinks in one day and no more than 7 drinks per week, or these little asterisks give them the ability to document their own wording and what they wanted to put in there. It even scores patient readiness to change was between 1 and 10, and they can put that in there on a scale of 0 to 10. Again, it has that we explored why it is not a low number and discussed the patient's own motivation for change. Patient agreed that he should cut back, abstain, or again, it gives the physician an opportunity to document, or clinician, whatever they wanted to. We agreed that Mr. Epic would benefit from, again, participating in a 12-step program, an internal referral, or an outside referral, calling the Oregon helpline to explore further assessment and treatment, and there's the number. It has patient will return in blank days to discuss how he was doing with this plan, and then it has your time statement. So this is a sample form we have on our website. This gives you an opportunity to really understand what is in our note. Now, in front of you is a sample. It's pretty similar to what I just showed you a second ago, and you can download this, and you can then take it and create your own logic, whether you use Meditech, whether you use Centricity, whether you use NextGen. We really wanted to provide you with a sample that would give you what you need if you don't use Epic. And again, Epic is not the best medical software in my mind, but it definitely works with us, and so do other electronic health records or practice management systems. So we're going to start in a second. That's going to show you a video of exactly how a physician would document. Dr. John Munch is our medical director, who I work with quite frequently with our SBIRT initiative. So this is him narrating how he completes an SBIRT. If you can't see this, or this video looks too small, or just doesn't appear big enough, or it's fuzzy because the bandwidth of your clinic isn't as fast as needed, I showed you Oregon SBIRT. Under the reimbursement section, this same video is on there, and you can click it, and it's much clearer. But just so you know, that video is out there. And can you go ahead and show that? Alcohol. It will bring up the tech-created tweak for this purpose, and we'll tab through to the first section and document that her audit score places her in the low risk zone. Because of this, So from looking at this video, it really lagged out on my end, so I actually couldn't even hear. I hope you were able to see that. Just maybe emphasis, here again, if you type in Oregon SBIRT in Google or in Bing search, and you go to this page, what you just saw, and hopefully it worked, it didn't show it working on my end, and I have high internet, you click on your reimbursement, click on clinician note, and your video is right here. So if you were to click on this button, it would open up and you could watch this video on your own time, and hopefully it's more clear. I showed it lagging out a lot. I hope that's not how your system showed it, but I couldn't follow along on my screen, so I would assume the same thing happened to you. So on your clinician notes under reimbursement, click on this video, and it'll work much faster on your bandwidth when you're not connected to a webinar. And this really goes through how a physician would document. We've got a lot of feedback from physicians, and again, if you don't have Epic, well, we gave you different ways of how to pull the same information we did in handouts. The sample I showed you, right here is one. You can actually download this document and then use it however you want, and then integrate that into your own electronic health record. And we have that all available for you on our website. And I'd like to point out, too, that this has been a great tool that's used with Centricity, used with NextGen. It's not Epic. It can be any electronic health record. So let me focus, too. Our real key was create front-end training that carries forward, but also it really gets the back-end billing done. And by having this smart phrase and this smart set, it has taken what it would take a clinician about 10 minutes to do the documentation to literally about 3 minutes. We have medical residents, maybe because they're younger, they can do their documentation that completes edit and repeats all requirements within a minute. And again, I know that my little 2-year-old knows how to use my iPhone, and I don't. So that's kind of interesting. But again, we've even had physicians who've been practicing for 30 years pick up Epic and use this tool and be closed within a minute or two. So technology has its benefits when used right. And apparently any teenager or kid understands technology at a level I can't understand. So one of the things we like to focus on is see the big picture. And this is a great example about how even people who think they see the picture don't actually see the big picture. So you have that person in the middle, he clearly thinks he sees the big picture, and then you have a person on the outside of this little picture who really does see the big picture. So I want to really focus. There has been a lot of literature about SBIRT, a lot of it, and I haven't read one single article that I view on the billing side as correct, because everything I've read is only specific to primary care private practice model. In the nation, that's only 20%. That's only 20% of how people bill in the nation. So what I'm saying is that I've read a lot of articles that say some frustrations with billing SBIRT, but that's only 20% of the nation. So for many of you who are on this webinar looking at this, I hope when you see provider-based billing, if you know what that is, then you're in the right place. So provider-based billing is a specific designation that only locations associated with the hospital can get. But what it basically means is instead of billing the professional charge, you also bill a facility charge. So the patient gets 2 bills. So the patient gets billed for the provider time, then the patient gets a bill for all the clinic time, the room, the time the patient was in there, any resources used at the clinic. And so a good example of this is if a provider sees a patient and bills a 99213, then there's also a facility charge comparable to the 99213 that's billed. So the patient gets 2 bills. Facility billing, this again is specific to outpatient center connected to a hospital or a location that gets a designation for facility billing. So again, if you're doing these 2 types of billing, you would know about it. There's also home health care, which is like home visits. There's also billing for residents. Many medical residents who are doing their internship or first year all the way to their 4th year, there's a different system for billing for them. There's also urgent care billing, and there is encounter rate, rural health care, federally qualified health care, and our tribal or immigrant work. So I'm showing you that this is how a lot of other people bill. It's not just primary care private practice model. So hopefully, if you're on the listen to this webinar and you realize, yes, we do provider-based billing. Yes, we do facility billing. Well, I'm actually going to walk through each of these examples and explain how it can be done and how you can use SBIRT and get paid for it. It also can be an inpatient, whether it's in your ER room or your ED room or observation care, or even if the patient's admitted to the hospital, you can still bill for SBIRT. So for all of you out there in this webinar, what I'm trying to tell you is SBIRT can be done, and it can be done in all these different scenarios, and we're actually going to walk through a lot of these today. So in advance notice, every time I talk about billing and coding with a physician, it puts them to sleep. So I can't joke enough about the fact that I hope you have coffee or something nearby, because if there's a clinician on this call, they probably think, one, we're evil people, right, because we have to restrict them what they can do. But at the same time, it does get very complicated, and it's outside of the norm. So I have another video, and I really hope you can hear it and it follows along. It's a video that is just a sample of when a patient presents and how the SBIRT can be initiated. At the same time, this is also on our website, along with a lot of other videos that you can hopefully watch. Connie, if I can get you to click on that. This is a video that walks you through when a patient checks in and presents for SBIRT.
Good morning. How may I help you?
I'm Alex. I'm here to see Dr. Winkle.
I see you have an appointment today. As I check you in, will you fill
It's just a few questions we ask our patients once a year. Thank you.
The annual screen is a short questionnaire given to all patients once a year. Patients who
So I must say that video looked amazing. So I think you guys saw that very clearly. That's just a sample of how we've integrated SBIRT from the patient side into the medical home. Now I'm going to talk about how that can be built, and again, the video clarity for me looked amazing. So I want to focus on an annual screen, a full screen with a brief intervention, or a brief intervention plus a referral for treatment. We're going to hit the billing side too, but I want to walk you through this so you really understand what we just showed you. Each of our clinics has an annual screening. What that is, it's a 5-question questionnaire we give to all of our patients once a year. The annual screening contains 2 questions for alcohol, 1 question for drugs, and 2 questions for depression. So what we do is when we give that annual screening, the patient fills it out and then presents it to our doctor or any clinician, nurse practitioner, physician assistant. And so when they present, that's given to the clinician, who then scores it in front of the patient. That also gives them a great opportunity to, whether they were there for something else, do a brief intervention. What we've noticed heavily in Oregon is that there is rampant alcohol and drug abuse, and the patients might not even think that they're abusing it. A lot of our admissions to our hospital, a lot of our admissions to our urgent care are because of drug abuse, but when the patient presents, they say pain. So even though chest pain or dizziness is on the note, it's actually related to alcohol or drug abuse. Now for primary care, that's also an issue. When patients present and they say, I'm having a lot of stomach pain, in your discussion you find out they're drinking tons and many beers or alcohol or hard liquor. So this is where this integrates into our method. So the annual screening is that 5-question questionnaire they get once a year. The full screen is as we go forward. Oh, sorry, I need to backtrack. So this is our the 5-question questionnaire. This sample is actually on our website for you to download. You can download it a PDF or you can download it in Word, and then you could change it to the letterhead or whatever you use for your clinic. So we're actually giving you a free tool, and this is how it's been successful for us. So when you see this code 99420, I really want to focus on that because it's something Medicare does not pay for, but our local Medicaid and our commercial payer does. So what this is you're not billing for this form. You're billing for when this form turns into a positive, but when you do the audit or DAST, it turns out to be into the low risk. It pays around $7.23 for our local Medicaid, and it also pays around $18 to $25 for our commercial payer. So what I'm saying is when a patient actually clicks one of these, and so it makes you from the pre-screen to actually turn into where they complete this audit, and if they score within this area, this is really not risky. But billing a 99420 gives you the opportunity to collect reimbursement for the fact you had to complete you had to complete the audit with the SBIRT process, but you never really did the documentation for the full intervention. So I'm going to be really specific because I think I talked over myself. What I'm saying is that billing a 99420 gives you the opportunity when a patient scores in that they need an audit or DAST from the pre-screen, but when you do the audit and the DAST, they score in the low risk or no risk zone. So you don't want to bill the SBIRT codes, the 99408 or 99409, if you technically didn't do an intervention with the patient. But it is nice to get credit for taking like 5 minutes out of your time to do this in the first place. So billing the 99420 gives you some revenue for that. Here's also a sample of our alcohol screening questionnaire. Again, this is on our website for you to download. You want to do the SBIRT when you hit these high risk or risky scenarios. Now, we've really done a lot of analysis and understood that SBIRT can really pay for itself. It all depends on the way you create and the workflows you create in your clinic. So again, on our website, we have those for you, from videos to trainings to role-playing. We explain how you can integrate SBIRT into your practice. So again, that 99420 gives you an opportunity for getting revenue when the patient tests positive for the needing for an audit or DAST, but then when they do the audit or DAST, it places them in low risk. you really don't want to do an SBIRT when there's no risk to the patient in our primary care model. But we do a SBIRT with intervention when they score within risky, harmful, or dependent. So how do you bill for this? Let's start under the primary care model. So under the primary care model, when you see a patient for a 99213, we reimburse our providers off work RVUs. You might provide them base salary, or you might have a different ingenious way of incentivizing providers, but the model we use here is off work RVUs. So when a physician does a work RVU of 0.97, that's for doing a 99213. So usually how people code for SBIRT, if they're not using these codes, if they're not using the 99408, they're upcoding from a 99213 to a 99214. So our local payer mix, as well as our entire SBIRT initiative, is focused on billing these SBIRT CPT codes. The reason is it's reportable. The second reason is it's really the code we should be using for when we're doing a screening, brief intervention, or referral for treatment. That's the code we should be using. So how we showed incentive for our providers to do it is when they do an SBIRT, they add a 25 modifier onto the 99213, and then they bill this add-on code of 99408, which gives them an additional almost level 3 work RVU. So as you look below, if a provider upcodes to 1.42, they actually get more work RVUs using the 99408 code. At the same time, there's no co-pay associated with these 99408 codes or 99409. There might be deductible and co-insurance. So it might lead you to think, oh, a patient might complain because now they have a special, well, they have a new copay they have to pay. They have a new co-insurance or deductible they have to pay. And I'm happy to say that we're not seeing that. We're actually not seeing patients calling in complaining. In fact, we're seeing a lot of patient interaction with providers that they're getting a richer experience. So what I'm trying to say is that by adding the 99408 to the billing, because this is an add-on code, your claim would have a 99213 with a 25 modifier next to it, and it would have the 99408 underneath it. Your provider gets incentive by their getting additional work RVUs in association with their 99213. So the 9920 code has no work RVUs, but we actually created custom work RVUs where they got like 0.10 or point whatever the number is you create. And so it gives the providers a little incentive to use it. But in the most, this gives you a real incentive just to get paid for doing the paperwork for the intervention, even if it never happened. So this is our clinic setting of a normal primary care practice. We're actually going to get into the specifics of all the other billing scenarios, as well as how to pay for alcohol and drug addiction counselors, licensed or unlicensed social workers, and licensed psychologists or unlicensed psychologists in just a moment. I want to also focus on all those primary health centers or primary care practices that are associated with hospitals, because you can also bill this in the inpatient setting. Your professional charge would pretty much mirror how you would bill under the professional side for a primary care practice, in that these codes are add-on codes that in billed with your E&M code for a low level, if the patient's already be admitted, you're just following up. So you get 0.76 work RVUs, and then now you get an additional 0.65 work RVUs. So by doing the SBIRT in the inpatient setting under professional charge, the provider gets double the work RVUs almost. So right there, that's a huge incentive for a healthcare provider to do the SBIRT on the inpatient setting. For those of you who are wizards in inpatient billing, there's also the facility side. So when you're admitted to a hospital, you're always billed a professional charge for the providers, as well as a facility charge for all of the things that the hospital did, whether administering medication, whether the nurse came and stopped with you, or other people worked on you, or your equipment that was used, or the time spent in the hospital. All of that is created into diagnostic-related grouping, And there's DRGs, diagnostic related grouping, for doing the SBIRT, where it can generate $50 to $350 depending on your contracts and how you're set up for the hospital. So what I'm trying to show you is that if you're doing SBIRT in the ED, the ER, or in the inpatient setting, not only can the provider be paid and incentivized, but so can the hospital. I've heard a little bit of, well, how can SBIRT be successful? Most of these grantees are really looking at how can we take SBIRT and make it self-sufficient. So what I'm trying to show you is that if you're currently doing SBIRT and you're not billing for it, then you're leaving $500 to $350 on your table for the hospital side. You're also leaving that revenue for the professional side if you're not billing for these codes. If you're upcoding to 99214, you're really not coding correctly. Now, I know providers say, well, just let me focus on treating patient care. But if you're not billing appropriately and you're also not documenting appropriately, then that's really not good patient care. So what I'm trying to show you is that if you start integrating what we're talking about into your billing system, not only are you improving the patient's care, but you're now collecting revenue that previously has been untouched. So the facility billing, on our website, pretty soon, you're going to see not a document like this. We really took all of the billing of how to bill for all these complicated health systems. So if you're a primary care practice associated with a hospital and you do provider-based billing, we have a document that walks you through exactly how to do it. And we're creating if-then logic in the document so that when you go to our website in 1 month and you type in, like things will appear that say, I'm outpatient centered clinic attached to a hospital. Clicking on that, it would walk you through exactly how to bill for these services. If you were to click on there that I'm a freestanding primary care clinic, it would click on it and walk you through how to bill for it. If it says, yes, I'm a facility billing provider, then you can click on it and it would walk you through how you bill for facility charges. So we have this document. Here's the document. Honestly, when I've looked at confusing documents on the website for other people, it doesn't really help me. So we took that and said, well, how can we make it easy to understand? So I'm happy to announce that in 1 month, you'll have a tool you can go to that would walk you through every single type of location you are to bill. So if I'm a home health location, it walks you through how to bill for SBIRT in a home health setting. If I am an assisted living facility that has a physician on site, it walks you through how to bill for that. If you're a health system, it walks you through how to bill for it. If you're a federally qualified healthcare center or a rural healthcare center, it walks you through how to do it. But today I'm going to walk you through the facility billing side. So what is facility billing? That's billing based on the physical time, not physician time. It's the physical time the patient spent in that room. It's when I say staff time, it's not physician, it's not nurse practitioner, it's not physician assistant. This is anyone who's a resource provider. Facility billing is a tool. It gives clinics associated with the hospital to bill for the other resources, not including physician time. So staff intervention, when the patient checks in, the time it takes the staff to check him in, the time it takes the patient to be roomed, the time it takes the MA to clean the room, the time it takes the MA to do some of the services, all of that counts as a facility resource that gets billed. And these resources create a point system, and I'm going to walk you through it. It also takes into account the time patients are spending with nurses. So let's say the physician does the SBIRT, and then a nurse comes through and does more education. You can actually bill for both of those interventions. So how people create facility billing sheets are as different things give points, like vitals give a point. This is a little blurry, so I'm going to jump to this screen, a little more clear. So all of these different things give points. Dressing, wounds, pelvic exams, anything done by someone who's not a healthcare provider, like a physician assistant, a nurse practitioner, or a PA, creates points that then get tallied here. So when I gave you that example of a physician charge and a facility charge, we have licensed clinical social workers, unlicensed clinical social workers, we have alcohol and drug addiction counselors, we have a lot of different providers that are what we call ancillary or resource providers. So when a provider sees a patient and you have provider-based billing, what that means is anything the provider does creates a provider charge. But now let's say the physician does the SBIRT and does a warm handoff that day, and that warm handoff means that the physician says, I have a great social worker who I want you to meet with, who's going to walk you through ways to solve, and I'm phrasing that pretty poorly, but is going to walk you through some scenarios and walk you through how we can help you limit your dependency on drugs or alcohol. It gives you an opportunity for that person to then meet with the patient. And as I said, you have two bills. So let's say the provider sees the patient and bills a 99213. The facility side mirrors that, where there's a level of service 1, as you see in this document, 2, 3, 4, and 5. So you can get a professional charge of a level 3 for the provider, but you can get a facility charge of a level 5 for the facility. Now, for facility billing, we actually can have an appointment that day with a patient for a licensed clinical social worker, an unlicensed social worker, an alcohol or drug addiction counselor, or a licensed or unlicensed psychologist who would actually see that patient and do treatment. And for facility billing, for outpatient facilities that do this, you can bill depending on the time spent with the patient and depending on the resources used. You'd bill a facility fee of a 1, a 2, a 3, a 4, and a 5. So what I'm telling you is you almost get reimbursed the same amount as a provider if you're attached to a hospital. Now, what if you're not attached to a hospital and you're a regular primary care practice? Well, this is how we set up our tracking with Epic. So with Epic, every time a patient presents, we do an annual screening. That's that 5-question document. And we set up, as this little PowerPoint shows, a patient message, and this is what it says, so that when the patient presents next year and the time has hit, a message pops up that says this patient needs an annual screening. So that's the dead giveaway for that office staff to give the patient that document. Well, at the same time as your primary care practice, you need to document that doc flow sheet. You saw in that video how the provider met with the patient, completed the audit, that alcohol paper, and then slid it into a slot, and then that medical assistant took it. What that medical assistant did is she went into an encounter, she went to the alcohol substance screen, she completed the patient's score, and then completed where it hit the patient, where if they fell into high risk, zone 1, the low risk, zone 2, risky, and so forth. There's even a slot for the completed alcohol score that fills in each answer. And again, this is back to the SMART set for the provider. This is that tool the provider can click on the documentation, can click on the alcohol and screening, can click on the CPT code, can click on the medication order, can click on the lab order, can add a referral to those people I talked about who, since we're associated with the health system, can be doing consultation visits and being paid pretty well for it. And so that's how we've kind of tried to solve the just have a provider do it. So if you're doing facility billing or provider-based billing, you're basically getting reimbursed under the facility side for having these extra people working for you. But if you're a private care practice, how can you get paid for having alcohol and drug addiction counselors, licensed clinical social workers or unlicensed, and how do you really get through paying for this? Well, you don't have to have Epic to do our Smart Set and Smart Phrase. You can have Meditech, Centricity, and you can take those same tools we did and adapt it to your electronic health record. The word Smart Phrase and Smart Set is only specific to OCHIN. Centricity has a word called Hot Text or Hot Links. It's the exact same thing, worded in a different way. Each of your electronic health record should have a system like ours is. It might not be called the same thing, but it can do the same thing, where it's quick coding for a provider. Who can bill? So under these codes for the 99408 and 99409, and their offshoots for Medicaid and Medicare. In our state, DO or MDs, PAs, nurse practitioners, RNs, or LPNs can bill those codes. But licensed clinical social workers and licensed psychologists can also bill those codes, but they can bill under a 99211 in a primary care practice. So how many people get away is they use the Incident 2 billing rules. Now, I'm not going to tell you all those billing rules, but I'm going to tell you that this is a way for you to bill for your licensed clinical social workers. On average, you get $15 to $19 with Medicare. You get around $7 to depending on your contract with your local Medicaid to $15, and you get around $27 to $68 for the 99408 commercial payers. We're noticing around $110 for the 30 minutes, the 99409. There are different ways you can bill for primary care practice that really can give you incentive. We have really learned that the Incident 2 billing provider, it also gives healthcare providers a chance to really check on the notes that are written by the alcohol and drug addiction counselors, and it really gives that added connection. What we do is every time a patient is seen by an alcohol and drug addiction counselor, a licensed clinical social worker, or an unlicensed, they route the note to the primary care provider, who then looks at it and under Incident 2 billing co-signs the note, and the bill can go out with their name on it. So the 99211 versus facility billing, what I'm trying to show you is it's not as negative as some of the healthcare providers have said. There are really good ways to bill for SBIRT and to make it self-sustaining. Whether you bill a 99211 and you include alcohol and drug addiction counselors, whether you have licensed clinical social workers who bill under their own license or bill under the physician's license, you can integrate SBIRT into a primary care practice. Whether you're a facility that does facility billing because you're attached to a hospital, there are really good ways to do SBIRT to have patients get that care they need and to be well paid. So one of the things, it does take payer interaction. We had to take 6 to 8 months to do it, but I'm lucky to say that in Oregon, the information I showed you, it passes with high grades any audit on medical documentation. We really started using our Epic billing system to maximize how to bill. So instead of having a provider remember all these different codes that changes yearly, why not have Epic do it for us? We created documentation that really flows with the clinician's response. What we did is we worked with the provider and said, what makes the most sense? And the provider created the medical documentation you see before us. It wasn't billing saying, this is what you have to have, do it. It was working together and actually making billing silent behind the scenes. In fact, most of our providers, when we trained them, didn't even realize we were training them on coding because we created that if-then logic and all of it was done behind the scenes. They really thought they were just being taught on what to document. And we focused on that front-end training with providers, on showing them the incentives of, hey, if you use this code, not only does you get more pay, but you do better patient care. And then we had our clinician champion, Dr. John Munch, who really stood up and attending our board of directors meeting. He really focused and was an advocate for the SBIRT process. I'm missing Jim Winkle. He's been our director for this initiative with Oregon, and he has been our Oregon SBIRT director. He's the one who helped create that webpage. He really put a lot of heart and soul into creating something that is used all throughout the nation right now. So as I'm finishing the presentation part and we start for Q&A, I really want to show you that when SBIRT services are embedded within clinics and hospital systems, it has only been shown to improve healthy patient outcomes. Any health facility can run a successful SBIRT program. All it takes is the right person and preparation and the ongoing dedication to it. You can use any electronic health record to really make this more efficient. And what we've noticed, it doesn't add extraneous overhead. I'll tell you right now to everyone listening that SBIRT can be self-sustaining. We've shown it is. We've shown that by creating systems where the provider isn't being taught billing, but they're only being taught how to document, and by putting the billing behind the scenes, not only do providers actually are more attentive and listen, but they do it because we're teaching them how to. We're not teaching them how to code. We're teaching them how to document. That's what they're used to. And I'm telling you right now that if you're not doing SBIRT, then you're leaving money on the table. If you're not doing SBIRT or not billing for SBIRT, you're leaving good patient care out the door, and you're losing revenue opportunities. So that's really my presentation. I'm pretty sure now. I'm open to any question. If you have any question, as complicated as it might be, let's talk about that right now. I know we have some time. So I did have one question that was sent to me privately that said, can you use Epic smart phrases in Centricity? So the word is yes, but it's not the same wording technology. Each electronic health record has an opportunity within it that you can create smart logic within it, and you can do the same thing we did with our Epic smart set or smart phrase. For those of you who do provider-based billing or do facility billing or do some of these special things that most people don't, I'm also open to answering your questions. For most of you private healthcare models, or if you're even certified for a primary care model home or medical home, ask a question. I'm here to answer them. You're going to get your answers.
And Joseph, we do have one question. How complicated is it to set up Epic smart phrases and sets? Is this something smaller clinics can handle?
Yeah, great question. What I did, this is how I made it easy. I met with a doctor who was a champion for the clinic, and I said, what medication orders do you have? What what labs do you think are recommended for this? And I went myself and I sat with them and I wrote what those numbers were in the medical record, so that when it was easy, because I was able to then work with the IT guy and say, this is exactly what this clinic selects, and we created this smart set and smart phrase to each clinic. It only took maybe an hour and a half of me sitting with the provider. It took me writing it up, which was really quick, and then it took me meeting with the IT guy and saying, make this happen. And that was with Epic. It was fairly painless, and at the same time, providers love it. If you want, I even have a sample of what we use, and so if you request it from JBS, then I can send that to you, and it's just how we did it, and it's mapped out pretty easy. I'm really confident that anyone can do it. First of all, I'm not the smartest man in the world, and I can do it, so I'm fairly confident anyone can. I'm the second smartest man in the world. Any other questions?
I am not seeing any questions at this time.
Do any of you have trouble with billing that you want me to answer or anything to? I mean, are any of you running into roadblocks, or what are some of the concerns you see?
And we do have one more question. For FQHC that receives encounter rates, will we receive additional reimbursement for SBIRT?
So for those of you FQHCs that get additional encounter rates, what you actually get is more reimbursement up front and less on the reports. So by adding the CPT code, your Medicare intermediary will pay you more up front and you get less on the encounter rate. How that worked for us is, honestly, sometimes we miss patients on these reports. So what it means is we actually get more revenue up front, which is great for our clinics, and we get less when you submit the RAP. So yes, you can. Yes, you get more money up front.
And another question, does Practice Partners have any of these options?
And maybe you could be specific. Is Practice Partners the electronic health record you use? And the answer I'll tell you is that what we've had to do is we had to actually call Epic and just say, hey, does this function? So if you have electronic health record, call your user rep, who is your person you call with questions, and ask them, how can this work? And if you want a copy of all our information, it's on our website. It's also something we can send you after this presentation so you can walk them through what you saw today, and you can ask them, can you do this? We've helped many different types of practices set this up, and we have not had a problem yet. So we've used NextGen, Centricity, MedManager, all of these different electronic health records have all been able to do it.
And our next question, to pay for warm handoffs to CD providers, is it best for a provider to bill for with a SBIRT code or an evaluation code?
Great question. So we have our providers bill the SBIRT and also count time when they're doing the warm handoff. So if you're doing a referral and brief intervention and you're doing the 99408 code, we include the warm handoff because the provider is there. And what we really do is we don't have the alcohol and drug addiction people bill that time. We have that count as provider time because the provider's in the room. If the provider leaves, then we don't bill for that time. But that first visit is what we call BRT, and that's building relationships of trust. We've noticed that providers and patients, if a patient does a warm handoff, there's a 4 in 5 chance of that patient coming back. If the provider does an internal referral, there's a 1 in 5 chance of that patient coming back. We want to set those counselors up for success, and so our physicians do that warm handoff. If they stay, it's great. If they don't, it's okay. They've done the warm handoff. They've introduced this person. They've said, this is an advocate. This person works at my clinic. This person will help you. Patients love that. Patients love it when they get that warm handoff. That's only a benefit for that patient coming back. And it gives one-on-one time for that person to do BRT, and that's building relationships of trust. Patients, when you meet with them and you give them a little introduction, this is my history, this is what we're going to do, it soothes patients and makes them want to come back. If a provider says, I'm going to do a referral and they're going to call you, that's not so soothing, is it? And then when the person meets with the patient after, they then bill their own time and bill for either 99211. If they're licensed, they bill the SBIRT code. If they're unlicensed, they bill under 99211. If you're under provider-based billing or you're doing facility billing, then you would follow those facility billing rules, which pays almost the same percentage as if a provider had seen that patient that day.
And at this point, we have one more question. Could you restate the percentage of warm handoff versus routine referrals? Yeah,
routine referrals get a 1 in 5. A lot of the bleed off on that is that if you waste too much time doing the referral, you lose patient interest. Also, sometimes the referral call, there's a percentage even out there of when people call, they're kind of rude and it deters patients. Where if you do the warm handoff, it's a 4 in 5 chance of that patient coming back, mainly because they've established a relationship with the person they're going to meet, which is great, mainly because the healthcare provider they are comfortable with has just said, I trust this person, and then at the same time it gives an opportunity for you to build a relationship with whoever the alcohol and drug addiction counselor is. Lots of visits with providers are based off relationships. A lot of it is. And so you burn those relationships when you're rude to the patient, when you don't call the referral within a timely manner, which honestly, even the best practice, it takes 1 or 2 days for that to happen, and sometimes that's 1 or 2 days for the patients to talk to themselves about not coming back. So 4 in 5 for a warm handoff, 1 in 5 for a straight referral. Now, lots of specialists don't have these same numbers because patients have to go to them or they really have severe problems, but in primary care, those are the numbers we see.
And at this point, I am not seeing any more questions.
Well, great. Thank you for your time. If you have any more questions, I would say email us and we'll respond back to you. I really enjoyed my time talking with you. Again, if you have any questions, I'm here to help, and we have the answers. This isn't a webinar where a person gives a vanilla webinar. This is us. We have the answers, and we're willing to share them with you. And thank you for your time.
Ladies and gentlemen, that does conclude today's webinar. You may now disconnect your lines. Thank you, and have a nice day.